Hi, everyone. I apologize for being late. I've had back-to-back meetings this morning, so I'm a little behind. Thank you all so much for joining us. My name is Alexa Smith, and I am the International Partnerships and Programs Coordinator with the Office of International Programs. So, global health is a varied and exciting field to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world and with COVID-19 uniting the world to solve an issue, global health has never been more relevant. This year-long programming is designed to feature our experts in the field of global health, KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Each presenter will share their personal journey, educational background, mentors, books and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and the heartbreaks. We do have some objectives for our series. The learner will gain foundational information on pathways into global health and will be challenged to deepen knowledge on equality and mutualism, which garners true collaboration and global health exchange for everyone's equal benefit. The learner will examine existing attitudes around global health so that we at the University of Kansas Medical Center are trendsetters who move beyond the us versus them, haves versus have-not mentality. The learner will be able to appraise global health, including global health research, philosophy, approaches, attitudes, and the varied efforts in the areas of health disparities, health inequities, and community health. Our next presentation will be another career chat with Ms. May Maloba. She is the Country Director for Global Health Innovations Kenya, and that will be on Thursday, December 2nd at 11 a.m. Our presenter today is Dr. Halinder Mangat, and Dr. Mangat is a neuro-intensive care specialist with interest in formal training in public health for developing countries. He has been involved with neurotrauma projects in East Africa for the past 10 years. And now, without further ado, Dr. Mangat.
Should I turn my video on or?
That is totally up to you.
Okay, I'll, okay, my name is Halinder Mangat. I'm actually a new faculty at KUMC. So it's the first time I'm doing this. Pardon me if it sounds very basic. I would like to make this interactive, but still being of the old institution, I will pop up a few PowerPoint slides to test your resilience. So my personal background grew up in several different countries. I'm now living in number 10 and traveled a lot. Thought I had seen a lot, and then kind of I grew up and realized perhaps not. Went to medical school in India. It was very eye-opening by the time I finished my internship, which is infolded. I had delivered babies in the hospital, in the countryside with bare hands, done cataract surgeries, liver biopsies, and pleural biopsies, everything. And I felt I was going to save the world because, God, not a lot of other interns had done that. And I couldn't have been more wrong about it. About 11 years ago, I got involved with I was on faculty at Cornell, working in East Africa. I've lived in West Africa, but this was in Tanzania. And initially started off just did an observational visit, ran the neurology curriculum for 4 or 5 years in the second biggest university hospital. And since then, I've actually been working on neurotrauma care, which is my interest as well, at the National Institute, and actually in the process of writing a grant to put together a clinical trial site in East Africa. So that's kind of a brief background about me. I would just like to go over a couple of slides, and then maybe we could do an sort of an open mic, if you will, to have a chat about, what does this all mean? I'm not sure I still know what it all means, but if you, I will just share my screen with you, and just a couple of slides. I think a couple of things I was introduced to. I'm sure you can see my notes, given that I'm on a different type of presentation, but feel free to, I can make the slides accessible. The question was, what's this all about? And that prompted the question, what, global health, sure, we know global, we know health, but do we really? And so, the definition of health then becomes important as to, it's 50% of the equation. So, I'll run through a whole list, and, none of them are perfect by any means. And surely different contexts demand different viewpoints. The WHO, though, and I think these are the ones that are perhaps more important, define this as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And that's very important, how we moved away from absence of disease or disability, because, it could be that I believe I'm perfectly healthy, and the fact that I drink 10 pints of beer in the evening does not mean I have a disease, because there's no medicine I can take for it. But it doesn't mean I'm in good health. And so there's been a broadening of scope and purpose, therefore. And that's kind of progressed along. It means the enjoyment of the highest attainable standard of health. And that should be a fundamental right for every human being, without distinction of race, religion, political belief, economics, or social conditions. Yeah, one could pick holes through it. What does highest attainable mean? For somebody that might mean a lot of plastic surgery. For somebody, it might mean a heart transplant, which is possible but not attainable. So that the context becomes important. The key thing, though, is it's a basic human right without distinction. And the health of all people is fundamental. So what's the consequence of the definition? It's fundamental to the attainment of peace and security, and depends on the fullest cooperation of not just individuals and states. And without a political viewpoint on this, I just beg of you to see this just in the context of COVID, for example, right? It requires the fullest cooperation. It doesn't have to be governments, of individuals, but also of governments, health systems at every hierarchical level. Why peace and security? It became the framing for WHO to gain traction, especially during the HIV pandemic. How do we get treatments out to people who can't afford it? So it was framed as a global security issue, with, of course, for politically framed as what if everybody came here for treatment, we couldn't afford it. And matter of fact, till 1996 or 98, a US visa application form had a section that asked if you have HIV or not. And the framing of it started to make a lot of governments give money to less resourced countries. The achievement of any state in the promotion or protection of health is of value to everybody. There's unequal development in different countries, and this can pose a common danger. And we've seen that, again, within COVID. And then going on to maternal child health, development of child is of basic importance. We see, in spite of all the money we spend about 80 to 90% of all healthcare expenditure in the last decade of our lives. And therefore, maternal and child health, perinatal morbidity, mortality, and disease in the US are not in the top 10 in the world. And so on. It's part of the charter of the WHO, what is health? And I think the context depends, right? So one may have to develop their own concept of it. What does health mean here? What does health mean somewhere else? What does health mean in the Antarctic, where somebody was not so long ago incredibly sick and had to be shipped out after remaining there actually for a considerable amount of time. But the goal should be that we are able to provide the highest attainable standard of health as a fundamental right. Which then brings us to, okay, so health, that's great. Public health, international health, or global health. And I just brought this here because we talk about global health a lot. And what's the difference between the three? International health, global health, a lot of people do use interchangeably. Public health is usually viewed as having a focus on the health of the population of a defined area. It could be a community, could be a school, could be the school system, could be nursing homes, could be the state, country. And now we're looking after 100 years at global public health. But the use of that term has generally not been in vogue because we haven't needed it. International health, on the other hand, focuses on health issues and has traditionally been infectious diseases and maternal child health diseases or issues in less resourced or low income countries. However, one can argue that principles of public health that are applied to problems that affect a variety of countries can be called international health. So right now, are we seeing an outbreak that threatens international health? It does. So public health within the country's international health. And then when global health comes, when we come to global health, there's just such a diversity of what is global health. Something from an area of study, research, and practice that places a priority on improving health and achieving health equity. Well, that's heavily weighed towards health equity. People would say health issues that transcend national boundaries and governments, that require global forces to act upon. I think that's a very reasonable definition. And the British government uses something similar, that health issues where the determinants, not the disease, but the determinants circumvent, undermine, or are oblivious of territorial boundaries, and thus beyond the capacity of individual countries or organizations to act upon. And, I seem to like that. And if you want to make it really, really short, it's a collaborative transnational research and action for promoting health. That sounds a lot like political speech, or the worldwide improvement of health, reduction of disparities, and protection against global threats that disregard national borders. So it's all sort of in the same spectrum, but the UK government's definition is, the determinants are key, because as long as we keep fixing problems but not addressing underlying determinants, it's a lot of money spent rather than invested. So that's the key thing. Determinants, factors that disregard boundaries of political boundaries and therefore require broad aligned efforts. So I hope everybody's seen this cartoon. On the left side is equality, when you treat everybody equal. So everybody gets to stand on the same size stool. So the tallest person has a very good view. The other person's a bit uncomfortable, and third person actually has no idea what's beyond the fence, which could be, for example, access to healthcare. The tallest person is rich, you got the middle class, and then you have the impoverished. Equity means supporting each category to the extent that would make everybody be able to achieve the same level. And in a way, one could argue that the left side shows capitalism and the right side shows socialism. That's how it's argued that why should we give more money to the poor? They should just try and get a bit taller. And we know people just can't get themselves to be taller. It's an analogy, regardless. And so what's involved in health and its provision, the WHO breaks it down into 6 blocks. One is actually providing the service, but for that you need a workforce, information, knowledge for organization, medical products and technology, financing, which we always get hung up about, and governance, because financing just translates out straightforward to money. But at the same time, we spend innumerable dollars on medical products and technology that don't give us the return dollar per dollar that would be given if we moved a lot of that money, for example, to financing. And governance just takes up a whole chunk of money. And, is it cost efficient? Well, it's very difficult to make governance cost efficient because governance decides the threshold of cost efficiency. So that at the top of the pyramid. So each block should be at the same level, and there should be co-governance, where healthcare workforce has a role to play in governance as well. Just back to the economic models, how all this is paid for. Private insurance, there's national fixed insurance, progressive taxation, where you pay more tax and then a greater chunk goes towards health or education, and then countries that have fixed healthcare taxes. And as we live in a capitalist model, which is based on demand and supply, which requires perfect competition, the healthcare industry would provide a good or a service, but the principles for that to work optimally is that the service being exchanged is homogeneous. So one seller to the other, it should not be different. But we do know that underserved areas, the quality and intensity of care provided is not the same as you might perhaps get on the Upper East Side in Manhattan. Same with insurance service. Each insurance product can also be different, which directly impacts purchasing. There are a large number of potential buyers, but also a large number of sellers of the good that act independently. So there's no price fixing, but there's also no monopoly, for example. And the buyers and sellers readily know the prices at which the other is buying or selling, but also are well informed about what the product provides. So, so after you've had a baby, you get a bill and you say, what? I pay $200 for you to wash my baby, for example. And so within the health system, then like national, they're competing goods, non-competing goods. Competing, whether you use it or not, it doesn't affect another person's access. Competing goods, it does affect, whereas non-competing, it doesn't. Good examples are if you take up an ICU bed, it is now not available for another person, whereas non-competing goods could be, your access to national defense is the same as mine. If you use it, I still have it available. So those are non-competing goods. So that's just a fundamental of just a description of key components that I think become very important in how we view global health. I think a big chunk of what is now called colonial global health is service provision. People get on a plane, go to another country, provide a service, come back, which in the long run becomes incredibly detrimental. And the ethical argument as well, we went and saved lives by running a camp. However, the perpetual running of camps undermines the ability of the indigenous healthcare system to develop their own service provision for that. And now, as we've seen in COVID, where a lot of this funding has been pulled, suddenly a lot of countries are left vulnerable because there's nobody funding the clinics that have been funded for 10 years, because it's 10 years, but it's still ad hoc. So what I take away from it is we've been taught and we have our viewpoints. And back to, the cartoon, on the left is what reality really is. And it's incredibly important we realize it. But on the far right, it's a totally different way of looking at it. If we just remove the barrier, that makes the equity instantaneous. And that's where the argument of health for all, regardless of any property of the healthcare seeker, the system, the political boundaries, and so on. So in an ideal globally healthy world, it doesn't matter who you are, you should be able to, or one should be able to enjoy the game of baseball. In my case, I'd say football, soccer, football, but whatever is your flavor. So that's really all I had in terms of slides. I would really like to have an open mic kind of a discussion about, I've told you a little bit about myself, a little bit about what global health can be in different shapes and sizes. And maybe we can talk about what we should do, what can we do, or any questions. I did put everybody to sleep.
No, I did have a question. So you had mentioned how essentially funding these programs doesn't allow those communities to set up their own type of program.
Yes.
So kind of what would be like a method that we could help these populations, I guess, help themselves have that equality?
So I think the first principle I think that we're moving away is distinguishing that we are from different communities, because that's also thought to be somewhat a neo-colonial view of global health. How can we help people do that? Maybe it's just semantics, but how can we do that? So I can give you an example how I've been able to do it. We've developed, I mean, with loads of other people, we've developed a head injury and a spinal cord injury program in Tanzania. We've been working there for 10 years now. And most of what we do is we do not take equipment. We do not run camps. What we do is we have, so for starters, every Tuesday morning at 6 o'clock Eastern time, we have a Skype meeting. And we've had this for 10 years now, every single week. There'll be the odd week here and there where we can't make it. And we discuss, we have an agenda, we discuss difficult cases, but we also have a map of twinning in different activities. So education, research, and clinical. We kind of make a plan for the year. Once a year, we go there. We organize a regional program for education. So typically, we would do 1 day of basically lectures on evidence-based management of head injury. Another day, we would do spine injury. And then for the next 3 days, we actually only taught skills. We didn't go and do difficult surgeries. Now, we did, every now and then it did happen. And how I got involved as a neurointensivist was a 13-year-old girl with scoliosis with which she was living was operated upon and died post-operatively after everybody had gone from lack of basic critical care. And my first trip, somebody decided to operate on a very large brain tumor in a 9-year-old. I will never forget her name. Her name was Happiness. And as they were closing up, we needed a hormone, and we were told it would be available in Nairobi. It was 10 p.m. We were in Dar es Salaam. We supported her. We got all the medicines, but she died a month later. And so I think the key things are going there, doing all these complex things doesn't help one bit, because yes, one could say every life is important, but in the longer picture, building the capacity totally beats individually saving lives. I hope that somehow answers the question.
Yeah, it does. So I guess it would be more of bringing education to them to be able to sustain their own kind of clinics and treatment there even after we leave.
So I would say even there's a step even before that. We must measure what the knowledge gap is. Right? We quite often tend to assume there is a knowledge gap. I can tell you during my internship in India, and that's, oh, I shouldn't say it, but it's like 26 years ago, I did, the cataract surgeries without a microscope in a barn while somebody was holding a lamp. As I mentioned, I could do a lot of procedures. I think in a lot of these countries, people can be far more skilled than we are. So the first step really comes to identifying a priority. And the priority has to be local. Quite often we go with so I have the skill set, I will go and impart it. So I heard of a group that was doing epilepsy surgery in East Africa. And, I think about it, and, there isn't a neurologist in town. There are like 3 neurologists in the country, all 3 are in Dar es Salaam. The epilepsy is treated by psychiatrists. Are we really addressing it the correct way? So what is, the problem? There's the whole global burden of disease. So I can tell you head trauma is a high priority. Sub-Saharan Africa contributes to 10% of all head injuries across the world. And the days lost to disability run in hundreds of millions. The effect on GDP is hundreds of billions. Why? Because 80% of the victims are on an average 30-year-old males who make the maximum contribution to the economy. And so even identifying the priority would require a lot of work. Now, one might say, but it would be great for them to be able to do pediatric ultrasound, for example, which may be Dr. A's skill. But when Dr. A goes there and teaches pediatric ultrasound, we tend to forget that all those attending are now not seeing patients they would have been seeing otherwise. And it's quite likely Dr. A is going to stay there for a week or 10 days. And because, might also go for a safari afterwards. So, we also take away resources from day-to-day operations, which is in itself costing lives. So I think national priority by burden of disease, by economic impact of disease, and then an assessment of how is it currently managed, what is the knowledge gap and what is the resource gap. Does that answer it somewhat in a very roundabout way?
Yes, thank you.
Sarani has a question. For a medical student who's interested in being involved in global health, do you believe it's more beneficial to pursue primary care or specialized medicine? I think it depends on what you'd like to do. So my mentor asked me, I think what helped me crystallize it, and his question to me was, when I sat down, he said, we all come to the planet and use up a lot of things here. We should all leave a mark. We should hopefully all leave a good mark. You have to decide in what way will you leave the planet better than you found it, or the earth. And my skills are in intensive care, and I figured out not a way to how I could apply my skills. I tried to find out where and how would my skills be useful. So if one wants to make a career in global health, then it may also be totally reasonable to, after medical school, do a PhD in a form of global health, economics, health economics, and a lot of those things where there are lots of ways to work into it. On the medical side, again, I think if you look at burden of disease, where and what burden of disease, really, maternal child health is one of the top things. Now we're seeing hunger, starvation is going to be a big thing in the coming couple of years. we're going to see an absolutely horrid thing in Afghanistan, followed by potentially Ethiopia as well, and South Sudan ongoing. So, if you wanted to work on that, economics perhaps might be, health economics might perhaps be a good skill, but there isn't a single way. There are many, many different ways. I can tell you, I did medical school in India. I did a master's in neurochemistry in Sweden. I did a medicine residency, and neurology residency. Then I did my fellowship in neurointensive care in England. And when my global health work got very, very serious, I actually took a sabbatical a couple of years ago, went to London and did a master's in public health specific for developing countries. So, I was like totally lost in the park, but not everybody has to do it that way. There are very, very many different streams of going into it. I think one of the, please post your questions or interrupt me. One of the biggest issues now in global health, the movement is decolonizing global health, because here's a very interesting fact that 90% of global health that is performed in low middle income countries is still being organized, financed, and carried out by people in the global north and more in the Western hemisphere. So who are working in the global south, which are the poorer countries. Now, which begs the question, how does one, take me, for example, I was in New York before this. How does someone from New York really, really, really know what somebody in Dar es Salaam needs? And to pretend to know so is not only deceiving oneself, but also deceiving the field, and it is now considered incredibly sensitive issue for the recipients of our enthusiasm, which may not always be well guided. There was not so long ago a chap who went around in East Africa giving people, was it tablets of bleach or something to get rid of diseases, and all sorts of things happen. I think it's very important to organize yourself, to be very transparent, to listen to what the folks on the ground are saying. Spend a lot of time on the ground itself, and the longer I work, the more humbling the experience is.
I really appreciate your comments on education and also listening. So often we'll have some students come in and they'll say, I want to go out and save the world, and I'm going to go and I'm going to teach this, these physicians what they need to do. And we really have to say, like, this person's been practicing whatever area of healthcare for like 40 years, longer than you've been alive. They know their population. They know what they're doing. And so the idea of the decolonializing is something we're still working on, and we've made some great inroads, really with the language and talking about working together and partnerships and international exchange, and and working with individuals such as yourself and doctors Quarantager and Butterworth with their program in Guatemala, where they're, they don't have plastic surgeons there. And so it's about training people to become plastic surgeons, so that way they can ultimately, do it themselves, so that people don't have to come in anymore.
Right. Well, I think legacy, I think there are different motivations for global health. Unfortunately, legacy seems to quite often get packaged into good intentions. I left Cornell, I was division chief, and people asked me, are you missed? How did it go after I left? And I said, no, I'm not missed. And people say, well, that's terrible. To me, that's good.
Yeah.
That system continues to work. It's agnostic of who puts it together. It's like children. I dress my kids today, but I mean, just imagine if I was 30 years old and I still had to dress my kids. I mean, that would be incredibly, I mean, that's when they have to dress me. So,
yeah, because it's like you mentioned earlier, in these health systems now, because, groups and money aren't coming in, they're not able to, take care of their populations. And so I think in that respect, a disservice really has been done, because they should be able to take care of themselves from just a basic health standpoint.
Right. I don't know what the median age of the audience is, but if anybody, I'll give mine away in a second. If anybody recalls, now knighted as Sir Bob Geldof, who held the Live Aid concerts in the mid-80s to raise money for HIV in Africa. And they were held in many different cities with large screens depicting African children dying of hunger and skeletons of African people suffering. And single-handedly, that has stereotyped in the minds of coming generations that is Africa. And it actually comes now from his own mouth, where he says it is one of the biggest regrets. They raised a lot of money, but it is one of his biggest regrets to have depicted those images. But it was catchy. It was on TV all the time, heal the world. And yeah, so I think we have to be very careful that we do not see that we stand taller, and that, at the end, we're all human beings. And, we cannot convince people in our own countries. I preface it, do not intend to make a political statement, the harsh reality, to take a vaccine. And, I would argue, on what grounds could we go to another country and say we know better, and we will convince you that, our way is better. A lot of money is lost. A lot of money is lost. I'll quickly share one little incident where we actually did a retrospective analysis in one of the cities in Tanzania, where there was a lot of involvement, actually from Cornell, where we saw a lot of children with tetanus in the ICUs. And over the 10 years, folks came and said, oh, you have to put them on ventilators, you have to do a tracheotomy, you have to surgically debride the wound, and you have to give them antibodies against tetanus. And this went on and on for 10 years. And I was very, very skeptical of it. So we reviewed 10 years worth of data. The death rate in the ICU prior to starting the program was 47%. The death rate at the end of the 10 years was still 47%. People died of other things. However, these are people who sold their houses for their children, their farmland, and it's a form of putting people into modern slavery. It's a well-known concept. Children will have to leave school to meet the expenses, will start working, will borrow money. So there are several downsides of good intentions.
Are there other questions? We do have just a few minutes left, so I do want to make sure if you've got a question that you are able to ask it.
I'm happy to put my email in the chat box if somebody wants to ask a question later. Please feel free to email me. And I hope this was controversially stimulating for everybody. And I really hope I haven't offended anybody by any of these, but you know, we think of things in a different way because that's progress. That's the right way to go. All right. Okay, doctor. Thank you very much. Shall we?
Dr. Mangat, we have another question.
Yes. Oh, sure, sure.
It says, many of our international organizations continue to operate under a neoliberal ideology. What are your thoughts on this?
If the person who's asking wouldn't mind defining what the neoliberal ideology is, because again, it's also an umbrella, if they can be a little bit more specific.
I was just referring to how many of those international organizations, such as the WHO, for example, are still run by global North powers.
Yes.
That have, are run by capitalist, neoliberal ideology.
So true. So that was the point of decolonizing global health, where a lot of the organizations, I think, even if before we get to the WHO, in the past, the biggest donors were government. Today, the Gates Foundation exceeds donations and economic contribution into a lot of these priorities over several governments. And are we going to see a corporation takeover? There is certainly that concern, because no matter how much we dislike our governments, they do regulate them. They don't, well, at least let me put it, they're not completely deregulated. There is a charter they follow. So while it's great what the Gates Foundation is doing, but is the governance transparent? As far as the WHO is concerned, I think it's, again, like a lot of things, self-perpetuating, in the sense that the whole structure of WHO was designed in a way that the global northern powers would control it. Now, the argument, and here is where it's totally, there's a contradiction of lack of equitable access in the governance structure. So at the headquarters now, for most positions, your nationality is taken into account. So for example, the continental health organizations that come under WHO, the leads are typically from that continent. But yes, when you get all the way up to the top, we've seen changes in the UN at least. However, as long as we have vetoing that is tied to the dollars donated, yes, that's a big problem. The second problem with the WHO is it has zero political power. So even if we change the whole structure, I mean, today there is an Ethiopian person who is the Director General of the WHO, and they've come under immense criticism, but it should be known that the WHO can only make recommendations, has no political power to enforce their recommendations. So I think even if the governance was completely transformed, it will remain to a certain extent toothless organization in executing the plans as they stand. And yes, I think this needs to change. The question is, how many countries that have criticized the WHO will give WHO the power the political power to enforce public health regulations in their countries? Not many. I do hope it changes, hopefully in your lifetime, if not mine. And we'll see we will most certainly see a far more pronounced effect. We're watching it today as the COP26 sits in Glasgow, and there are 180 or 200 private jets parked there, where representatives from the global north are there to talk about how much they can resist the change. I think it's happening right now. And that's, as long as we live in a money is power society, I think these are the immense pitfalls.
Well, thank you so much. I think this has been a great and informational conversation.
Thank you. Thank you, everybody, for coming. And thanks so much, Alexa, for the invitation.
Of course, we're so glad you accepted. And I will just make a plug for International Education Week next week. I sent an email out this morning, so be on the look for that. And as I mentioned earlier, our next Global Health series will be on December 2nd. So thank you all again, and have a great rest of your day.